Okay, there we go. Now we're being recorded. This is going to be posted to the committee's website in the days following the meeting. So now I will turn it over. I will make sure Pam is with us. Has Pam joined?
I haven't seen her yet in the attendees.
Okay, one moment and we'll figure it out. Pam is having trouble with the link. Let us pause for just 1 minute and see if we can troubleshoot that with her. One moment, please. I have just resent the link to her, and I hope that fixes it. And she is our chair, so we're just going to have to wait a moment for the technical difficulties to be fixed.
Hi, Mary. Let me know when you're ready to start.
We are ready to start. Welcome, Pam.
Thank you.
Good to have you this afternoon. And I was just about to turn it over to you to call the meeting to order.
Oh, good. Okay. I was having trouble getting into the meeting. For some reason, my Google Calendar was not cooperating with Zoom. So anyway, thanks. Sorry for the delay. So good afternoon, everyone. It's 2:04 according to my calendar. Thank you for joining us today. And I'll start with an overview of the agenda. As usual, we have a very full agenda. And there it is in front of you. So we will have an icebreaker today, as we like to use the opportunity of being together to get to know each other better. So the icebreaker today is, if you were a sea creature, which would you be? So I'll let you think about that while I review the agenda. After our roll call, we'll vote on approving the November meeting summary. And following that, we will hear public comments. Then Mary Franzen from HCA and Gary Cohen from the Health Management Associates will update us on the Commission's 2025 work plan and the progress on the Milliman analysis. After that, Cheryl Namagitit, and I hope I'm not massacring that name, will provide a high-level overview of the Healthcare Cost Transparency Board benchmark report as was presented to the board's public meeting. And I know we've all been eager to hear about this and have some time to ask questions and learn more. Following that, I will give a short update from the last commission meeting, and before we dive a little bit deeper into cost containment. And then next up, we will have Bob Murray reporting on hospital global budgeting. After Q&A with Bob, and we'll take a short break. And after that break, Todd Bratton from HCA will outline our path forward on cost containment design, with Gary Cohen facilitating. Our final agenda item today will be benefits and services modeling, and Gary will lead a short discussion on prioritization and other considerations for making our recommendations to the Commission. Before I turn it back to Mary, I just wanted to make a brief note that this will be my last FTAC meeting facilitating. I know Mary sent out a note. I'm going to remain an FTAC member, but our Our colleague, David DiGiuseppe, will be stepping up at the next meeting to act as liaison, meaning he'll facilitate and conduct the back and forth between our committee and the Universal Healthcare Commission. So thanks very much. Mary.
Thanks, Pam. I will go to roll call. And just as a reminder, if you could be any sea creature, what would you be and why? So first, I will call Chair Pam McEwen.
I had more time than most of you to think about this. So, actually, an octopus is my favorite sea creature. However, they are incredibly short-lived. So I think I would choose a dolphin instead.
Thank you. Christine Eibner.
Gosh, I was thinking dolphin too, but maybe I'll change it to orca whale. I feel like I want to be a mammal. Yeah.
Thank you. David DiGiuseppe.
Well, I was thinking orc whale, so now I have to pick something else. I'll go with a great white shark.
Oh, aggressive choice, David. Eddie Rouser.
Present. Yeah, so I'll go to the Finding Nemo clownfish. My daughters always give me a hard time about Marlin or Marvin, if it's his name of the dad, but I liked his personality.
Thanks. Esther Lucero. Ian Doyle. And we heard from Kai that he probably wasn't going to make it, but Kai Young. Okay, our next sea creature is Robert Murray.
Yeah, I've been sort of flummoxed here because you stole my first three picks, but probably I'd like to go to Ocean Beach in San Francisco and watch the seals and sea lions chirping. So it'd probably be a sea lion.
Thank you. And Roger Gantz.
Good afternoon. I think my pick held. I would like to be a sea otter for probably two reasons. One, they appear to me to much enjoy life. And secondly, as we've learned more about sea otters, they have a real positive impact on our shoreline ecosystem.
Thank you. Okay, and I will turn this back to you, Pam.
Thanks, Mary. I enjoyed that much more than I had anticipated. Okay, so please turn to the second tab in your materials where you'll find the summary of the last meeting. And as always, we'll use the consensus process for a vote on approval of the November meeting summary. Is there any discussion of the meeting summary or proposals or concerns? Okay, seeing none, I propose that minutes are accepted without change. Any discussion? If not, all in favor say aye.
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 Any opposed? All right, we are approved by consensus. Next, we'll move on to public comment. Committee members can find written public comments under tab 3. Individuals may sign up to provide public comments before the meeting, and we will hear from those individuals now. When you're called upon, please state your name and affiliation, if any, before speaking. We will be displaying a timer as a reminder of the 90-second time limit. When the timer stops, please stop your public comment. Mary, would you go ahead and please start with the names of individuals who have signed up to provide comments?
Sure, thank you, Pam. And just as a reminder, as we are sliding you over to panelist, may take a few seconds. And we had 2 people sign up ahead of time who wanted to offer comments. And the first who signed up is Peter Marcus. Peter, are you here with us?
It can take a minute.
Hi there.
Yep.
Yeah, hi there.
Hi.
Yeah, thank you for the opportunity to provide public comment to the Commission's Finance Technical Advisory Committee. I am a voter in the 31st Legislative District and commenting on behalf of whole Washington. We thank the FTAC for their work on the Washington Health Trust Analysis Report. We remind the FTAC that the report made commitments to continue their analysis in 2025 and ongoing until it is complete. To that end, we ask that the FTAC be aware that the latest version of the Washington Health Trust has been introduced into the new legislative session as Senate Bill 5233, and that all continued analysis we request be done on this latest version. The new language has incorporated recommendations from the Universal Healthcare Commission and revised its financing plan to be more progressive. This continued analysis should be outlined specifically on the 2025 work plan, and we hope it can be completed this year so that it can be used in our legislative advocacy in advance of the 2026 session. Yeah, and that's it. Thank you.
Thank you for your comments. The second person who signed up is Chris Curry.
Hello, I'm Chris Curry, retired RN from Spokane. I want to draw your attention to my written comment in your packet of materials that lays out the case for how a state-based single-payer system can greatly reduce the incidence of unnecessary medical procedures and therefore contribute to cost containment. In addition to utilizing a mandatory global budgeting approach to minimizing the financial incentives for unnecessary care, there are at least 4 other components, namely, enhanced transparency to better understand the motivations behind unnecessary care, practitioner education on best practices, an integrated data collection system designed to more accurately determine true best practices, and a governing body that is free from industry bias and powerful enough to enforce its regulations. I would therefore urge you to recommend that the Commission formally include adopting the single payer structure as a fundamental guiding principle in order to achieve genuine cost containment most efficiently. Thank you.
Thank you. Those are the folks who had reached out ahead of time to sign up. And now, if you would like to offer public comment, please put up your hand. Okay, I'm thus far not seeing hands. I do see a hand now. Aaron Katz. Aaron, I think you can go ahead.
Sorry,
There
I
you
was
go.
on mute. I was on mute. Sorry about that. My name's Aaron Katz. I'm a retired faculty member at the UW School of Public Health. Just to support what Chris just suggested, and this is a comment that I sent to Pam. I don't know if you all have gotten it, and to the Universal Healthcare Commission members, that I would really like to see you focus on the structure and design of the governance system first. That's probably the most important feature of a unified system in order to design something that will, in fact, control spending and assure equity and access for all Washingtonians. So I've urged you, and I sent this to Vicky as well, to really reverse the sequence of items that you work on for universal design to take up governance first. As I said, it's really the most important aspect of a uniform system for the purpose of assuring efficiency and access and cost control. Thank you.
Thank you. Right now we have one more hand raised, Aruna Bhuta.
Aruna, if you could unmute, you're a panelist now, so you can speak. Aruna, if you're speaking, we can't hear you. It looks like your microphone's still muted. Oh, there you go.
Thank you. Thank you for this opportunity. My name is Aruna Bhuta. I'm a retired social worker from Spokane. And I second what Chris Curry and Pam McEwen said in support of state-based single-payer system for cost containment, affordability for and affordable access to care, which is sorely needed for Washingtonians. Please support single payer system, state administered without insurance plans, but state administered so that the administrative cost is less and there is a greater access to care. Thank you very much for all your work. And I hope we will be able to have universal healthcare in Washington soon. Thank you.
Thank you, everyone. I don't see any other hands up. We'll give it just a second to see if there are more folks who would like to comment. All right, I think that wraps up our public comments for today. Thank you, everyone, for attending and for offering your comments. And Pam, I'll turn it back to you.
Okay, thanks. Thanks, everyone. And I just want to, as always, remind everyone that public comments are a really important part of the work that we're doing. We appreciate you taking the time to share. Committee members, now we're going to get an update on the 2025 work plan. This is under tab 4 of your packet.
Okay, and this one's mine, I think.
Mary and Gary. Yes.
Yep. I'll give Audrey a second to get there. And I think some of you have already, taken a look at what our work plan is for the year, but I thought it would be good to level set and catch everybody up. So if we could go to the next slide, please, Audrey. Oh, next one again. This is always a good place to start when we are, getting our feet on the ground and figuring out the plans for moving forward. This is what's in the bill that created the Universal Healthcare Commission. And it's conveniently highlighted, sort of highlights the two parts of their charge. One is the transitional solutions, which is to look for changes that can improve the system that we have in place now. Sometimes we call that interim, sometimes we call it transitional, and also design a universal system that ultimately there could be the universal system for the state of Washington. So the commission is always moving forward on both of these tracks as they make their plans and as they consider design elements for the system. So if we go to the next slide. One thing that the commission has asked for and other people have asked for is a tracker for where we are in the overall work. I mean, sometime in the past, I think this is before I joined the work, things were defined into phase 1, phase 2, and phase 3, as you can see for the universal system design. So we have the universal system column there, the transitional column where I know the print gets really tiny, and also the legislative reports, because we do report to the legislature every year. So anything that's green is done, and the far right column, the legislative reports, that's just going to keep turning green every year as we put together those reports. And so I'll call your attention to the left column, the system design. The 3 yellow ovals of benefits and services, cost containment, and provider participation and reimbursement. If we go to the next slide, back at our December meeting with the commission, these are what we proposed as the 3 goals, the 3 main goals for 2025. Complete the analysis of benefits and services, determine the prioritization, develop recommendations for cost containment mechanisms, and also recommendations for provider reimbursement and participation. So the next slide takes us back to the tracker, and there's an arrow that shows where we want to be. If I could have the next slide, Audrey. At the beginning of 2026, those yellow ovals to the left, maybe I called them orange last time, but you know what I mean. We want to turn those green in the course of 2025, and then early 2026, get to work on the financing. So that's what we proposed to the commission. We said, and also keep working on transitional solutions. The next slide reflects what their guidance was to us for the coming year. They liked the 3 goals for the universal design. They expressed a preference for how we time things. And that's partly because, the legislature convened, I think, Monday of this week, Monday or Tuesday this week. We swore in a new governor. We have new elected officials. We have a number of new agency heads. There's a lot going on, and that a lot of that will be going on pretty concentrated in the first 6 months of this year. So the commission expressed, let the legislative process and the bills, and we know these bills are floating around for admin simplification or for reference-based pricing, kind of let that settle. So we'd like to spend the first half of the year with us more focused on universal design. And then in the second half of the year, we'll pick up the transitional solutions again. They're not letting it go. That was just their preferred timing. They thought they could get a little more done that way. And I'll just pause for a moment on transitional solutions, because as you may recall, in the November FTAC meeting, we talked about prior authorization as one of the administrative simplification transitional solutions. That may be put on hold as a transitional solution for a bit, but it's not forgotten. But we are adjusting the timing, and we'll continue to adjust the timing going forward. So the next slide. This is our meeting schedule. This is the FTAC meeting schedule. You all should have received these invitations. If you didn't, please let us know. But these are the dates on the calendar for the coming year. And in each of those off months, we, of course, have a commission meeting planned. So the next slide. This one may take a moment to look at it and have it sink in. It's our representation of the flow of topics back and forth. FTAC to the commission, back to FTAC, back to the commission. And on each of these lines in between the meetings, there's a lot of work being done. There's staff work, doing research and distilling down the recommendations and absorbing what happens at the meetings and preparing it for the next body. And you can see we start out the first few months of this year with benefits and services and cost containment. By the time we get to April, things are in orange and red. Orange means preliminary, red means final. So we're hoping that by the time we get to the April commission meeting, which, believe me, will come up faster than any of us realize, there will be preliminary recommendations about benefits and services prioritization and preliminary about cost containment. Those preliminary recommendations get sent back to FTAC in May for recommendation, for fine tuning, for consideration, in the hopes that in June there is something ready for the commission to finalize. So I know this can be a little confusing to absorb all of these pieces, but this is how we see the year playing out. And if I could have the next slide. The next slide is the second half of the year. And it follows a similar pattern, just with different topics. If you notice in August, prior authorization makes a comeback, what I mentioned a moment ago, the preliminary recommendation for prior authorization as an interim solution. When you look all the way to the end of the year and we get to November and December, it says future topics. That's a recognition that topics will come up during the year, that we will consider different things. And frankly, sometimes schedules slide a little, and we wanted to leave ourselves some leeway and some room to take up things in November and December. Next slide. This, I think, is my last slide, which is the update that the Milliman analysis is ongoing. This is something that FTAC is working with Milliman on, and there are liaisons working with the Milliman team. So I just want to pause and say thank you to our liaisons, who are Eddie and David and Roger, who have been helping us hammer out the nitty-gritty details of this analysis. And there's a revised timeline from what we had originally. There will be an interim report that is to HCA only in February. And the reason it's HCA only is that, excuse me, all of Milliman's work needs to go through all sorts of verification and vetting and authentication process. And I know my Milliman friends are on the line, and I probably just used all the wrong words, but they need to make sure everything is firmed up and ready to go before they can release it publicly. So HCA, who holds the contract, will get to see the interim, and then the final report will be shared with FTAC and will be made public in March. And I think that is the ends of my slides. And I will pause if anyone has any questions. Okay, I think that means it goes back to you, Pam.
Okay, thanks, Mary. The next thing is we're going to hear from Sheriel Namagit or Namangit. Apologize in advance about what I'm doing to your name, Sheriel. But this is to hear from the Cost Transparency Board. I'm looking forward to this presentation. Thank you.
Okay, and actually the first couple slides are still me, and then we'll turn it over to Sheriel. So.
Oh, sorry, apologies.
Oh, no, quite all right. Been a lot of me this meeting. If I could have the next slide, Audrey. Just a quick background, and then Sheriel, I know you're going to share your slides, and when you share, if you could please select replace current share. That way, I think that will preserve the recording. So when you share, please select that, and I'll just go through one slide real quick. And this is, again, going back to the November FTAC meeting. We talked about cost containment. We talked about reference-based pricing and healthcare cost benchmarks. We had questions about the benchmarks and Washington's benchmark report, which is why Sheriel has joined us today. There also was a public hearing back on December 12th. That recording is available to discuss the report. And now I will finally turn it over to Sheriel, who is a health economics research manager at HCA, who can walk us through parts of the report.
Thanks, Mary. Thanks, Pam. Let me share my screen first before I start. Is that okay? All right. Okay, so for this very brief presentation, I'm going to present the background on total healthcare spending data and healthcare cost growth benchmark. That is the work of the cost board. And then we'll provide some highlights before we focus on the 2022 spending, particularly our comparison of the cost growth or performance against the cost growth benchmark. Then we'll look at the 2019 to 2022 cost growth as well, which happened during the pandemic. So before we proceed, the cost board, the Healthcare Cost Transparency Board has many data and analytic initiatives, of which one is the performance against the benchmark. So in this highlighted block here, this is one of the programs where we collect data on healthcare expenditure, and then we calculate the cost growth of various entities, particularly carriers and large provider entities, but we'll also look at the statewide performance and market performance, and then we compare it against the cost growth benchmark that was set by the cost board. So in terms of data, to be able to calculate the performance or the cost growth, we implement annual data calls. So the first data call was implemented in 2022 when the cost board collected 2017 to 2019 data from carriers as well as non-carriers here in Washington State. We also implemented the most recent data call last year in 2024, where we collected 2020 to 2022 data. So far the cost board has 2017 to 2022 data. And so the data that we have measures the total healthcare expenditure, which is represents statewide or overall spending, healthcare spending in Washington. And we call this the THCE, and this is broken down by total medical expense or TME, which is basically the total of claims and non-claims health spending. Then we also have the net cost of private health insurance, which is basically the cost of administering health insurance or private insurance, as well as Medicare Advantage and Medicaid managed care. And then we have also other spending. So for TME, this is broken down by market, particularly commercial, Medicare, and Medicaid. We also have a breakdown by carrier. And since carrier submits data for large provider organization, there's some attribution done to be able to get data by a large provider organization. On other spending, this is broken down by spending from state-run agencies, particularly spending or healthcare spending on veterans. That's coming from Veterans Affairs, spending from Department of Corrections, and workers' comp data from Department of Labor and Industries. On the cost growth benchmark, this was set in 2021, and we have 5-year cost growth targets set by the cost board. This is based on a combination of economic indicators, particularly from the per capita nominal GDP, as well as the nominal wage growth here in Washington. So in 2022, this is 3.2%. So this is the cost growth or the target cost growth for various groups. So we compare per member spending cost growth, particularly, or we also call it performance, against this target. And we do it at these various levels of aggregation, statewide, markets, by carrier and provider. But for this presentation, I'm going to just present the performance against the benchmark overall or statewide and by market. So our analysis showed that the 2022 statewide per member cost growth here in Washington reached 3.6% in 2022, which is slightly above the 3.2% set benchmark. And that this 3.6%, excluding 2020, is the slowest since 2018. If we also compare markets, only the Medicare market exceeded the benchmark. So commercial and Medicaid actually grew below the 3.2%. We also saw that spending for Veterans Affairs drove growth in 2022. But we also know that one-year analysis on 2022 year-over-year growth doesn't fully capture developments during the pandemic period. So we looked at the 2019 to 2022 growth. And what we saw is that per member spending growth is driven by actually commercial and secondarily the Medicare market. We also see on other spending that VA spending is driving growth during the pandemic. And per capita spending growth from 2019 to 2022 is led by these top contributors, particularly prescription drugs coming from Medicare and commercial markets. We also saw an increase in non-claim spending, particularly from capitation and bundled payments in the Medicare market. And the third top contributor to growth is hospital outpatient that we see in the Medicare and secondarily in the commercial market. Per capita Medicaid spending during the pandemic actually decreased due to a decline in other claims that more than offset an uptick in prescription drug spending in the Medicaid sector. So looking at the 2022 performance comparison against the benchmark, this is the data. We saw that per member per year spending overall statewide reached $7,702 in 2022, which is 3.6% higher than the level we saw in 2021. So just to give a perspective, this amount is equivalent to about 25% of a minimum wage earner's annual income in Washington in 2022. If we break down the per member overall spending, what we see is that we see a very high level of spending at the DOC, but this is only less than 1% of overall spending. So an increase won't really drive growth by a lot. But we also see Medicare to have like the highest per member per year spending, and it has almost 1/3 of total statewide spending. So it's growth in Medicare and the rest of the markets are the ones that are pushing growth in the state. So as mentioned earlier, overall or statewide growth grew by 3.6%. So to be able to know which component is like driving growth, we can look at like growth rates like above the 3.6% or to the right of the dotted line. And what we see is that Medicare market grew by 4.3% above 3.6%. NCPHI also grew by 6.7%, and then VA grew by 21.6%. DOC also grew, but again, it's like less than 1% of overall spending. So the overall growth rate seen in Washington is actually very close to the median growth rate that we see in states that are also implementing same transparency programs. In particular, we have Washington, Delaware, Connecticut, Delaware, Oregon, and Rhode Island. Now, going back, looking at 2019 to 2022 patterns so that we'll be able to capture the dip in 2020 as well as the sharp recovers in 2021. We compare the growth rates of the different components to be able to look at growth drivers within this time period. Overall growth rate within this time period is 7.9%. And if we look at the whole pandemic period, it's commercial that grew by 11.5%, that is driving growth during the whole pandemic period. We also saw growth in Medicare market, although it's less than the commercial market at 7.7%. Medicaid also grew by negative 0.1%. Although overall spending grew in Medicaid, we saw a lot of like enrollment increase during this time, and hence on a per member per year basis, Medicaid spending actually declined by 0.1%. There was some market growth shifting that we saw during the pandemic. So from 2017 to 2019, the shaded area here, we see that Medicaid growth represented by the blue dotted line was above the growth rates seen in other sectors, particularly commercial and Medicare. But after 2020, what we see is that commercial growth rate actually outpaced the growth in Medicaid as well as the Medicare markets. And then if we compare to other states, again, Washington overall is again within the median growth rate of other compared to other benchmark states. And when we look at the commercial sector, you'll see that they're bunching upwards, which means that commercial market registered the fastest growth in other states as well. The Medicaid market actually also like declined during the time, except for Delaware. Sorry, the animations are not working well. And if you look at the Medicare market, it's also growing above the Medicaid, but slower than the commercial market during the 2019 to 2022 period. And then looking at the contribution to overall per member spending growth by service category, the top contributors to growth from 2019 to 2022 are prescription drugs. So prescription drugs is represented by that green line. And you can see that in other service categories, there was a dip in 2020, but the prescription drugs kept on growing even in 2020. And then non-claims also contributed, the second top contributor to growth, and that's coming from Medicare capitation and bundled payments. The third contributor to growth is that orange line, and that's coming from hospital outpatient. And that is a summary of the benchmark results that we saw from our data call last year.
Your question from Christine.
Hey, Christine.
Thank you. Yeah, I was just wondering if you could say something more about there was very large growth in those two categories, VA and DOC, which I didn't catch what DOC was. And I wondered if there was some kind of structural shift happening there that might be driving that. It seems, I mean, I realize it's probably a small denominator, but the increase seemed extremely large.
Yeah, that's the Department of Corrections, the DOC. So the spending on institutionalized population. The VA, we actually just got like the aggregated spending. And so we actually don't know what's driving the fast growth in VA. So that actually, we had some conversation within ACA that maybe it would be good to actually get the disaggregated data and examine what is driving the growth in VA spending.
I had a question about non-claims spending, to better understand what would drive that, because it did seem to be a major factor in the data.
Yeah, so non-claim spending are spending that are not claims. So this is broken down by capitation or bundled payments. We have also performance incentives, recoveries. And when we look at the breakdown of non-claims, this is really coming from the Medicare sector.
But why,
And
why is
in particular,
why
yeah,
is it
so
going?
we are also looking at that, and it seems like there's like a lot of shift from Medicare FFS to Medicare Advantage. And so there's might be like some reallocation of spending from claims to non-claims as people move from Medicare FFS to more Medicare Advantage.
Are those arrangements with the hospitals in which they're, kind of truing up obligations to hospitals over care for patients in those settings? Is that what we're seeing?
We are actually having a discussion. This is the data is like very aggregated, so we actually don't know where it's coming from. So that's also one of the big questions in the cost board, and I think we will have a big discussion in the next cost board meeting, January 30th, to discuss more about that non-claims part.
Okay, thank you. And I see Roger has his hand up.
Yeah. Thank you. A couple quick questions, if I might. One is the benchmarks that you showed on earlier slides. My understanding was, is this accurate? They originally kind of arrived with a focus of looking at hospital expenditures and, if you will, the efforts and part of the transparency board in terms of kind of meeting those targets really focuses on inpatient and outpatient hospital services. Is that accurate?
I think the cost growth benchmark is really to set like a target growth rate for carriers and large provider organizations. And so since this is based, so in other states, what they do is that like they actually have like they compare carrier performance and large provider performance to the benchmark. And if they exceed, there's like some sort of like PEEP or like there's actually like disincentives or punishment if you exceeded the benchmark. But in our case here in Washington, we don't have any like legal consequence if you like exceed. It's more of like we're still determining. We're still like trying to increase transparency and like identify trends in the state, but like I think like moving forward as the program matures, we might look at like performance of large provider organizations and then, if they exceed, and then we will ask why, right? Like, is this coming from, hospital outpatient, increase in price or utilization? Like, it's still like at the very nascent stage. So we still don't have that like very deep analysis looking at like drivers of why like large provider organizations are exceeding the benchmark.
Yeah. Okay. I see Eddie has a question.
A lot of good data to review. Oops. There we go. Yeah, I was trying to look at the percentages at first, and I believe they're not in total. They're all in per member per year, correct?
Yes, yeah.
And so I'm just digesting, I guess, the information. I think I answered my own question. But the growth or the negative growth that occurred during the pandemic, and then as you exited the pandemic, and then the target that's set, it looks like it's just been very.
The pandemic didn't even happen.
Yeah, like sorry, Eddie, you were cut. So could you repeat like the
I was
question?
just looking at the overall spending throughout the pandemic, and it looks like if you take 21 and 20 together, there wasn't much of a dip in spending at all on a per member basis, and that's when the caseloads are swelling. And then after the ramp down, we maintained. So yeah, very interesting data for a per member per year spend. Thanks. I answered my own question.
Okay.
Yeah, thanks.
Thanks, Eddie. We are at time. Roger, do you want the last word? No? Okay. And Eddie, your hand's up, but I presume it's your previous question. Okay. I'm going to go on to the presentation on the commission meeting. And thank you, Shariel. It's really, we are all wanting to dive into that data a lot more.
Thank you. And we will publish the more detailed brief or like the benchmark report. It should be in our website soon, like either like early February or middle of February. And that will have like more detailed discussion, like carrier performance, large provider performance in that report.
Yeah, we hope that there'll more opportunities for conversation with you and hearing more about the work.
Yes, yeah. Thank you for having me, and like always, happy to share the insights and the data that we get from the cost per site.
Thank you.
Thanks, everyone.
Okay. Tabs. This is my brief slides are under tab 6. And we go to the first slide. So I guess the next slide after that. So the Universal Healthcare Commission is understandably grappling with all the same things that we are, which is, looking at some of these cost issues. And at their last meeting, they had a very robust discussion on the reference-based pricing bill that is now, I think, been dropped to the legislature. Following the presentation, the commission voted to support the principle of reference-based pricing, knowing that it's a meaningful and significant way to impact the cost trend and rebalance resources, but also recognizing that we were at the very beginning of the process and that things can change a lot during the legislative session. So the important thing was supporting the principle going forward. And I shared our conversation with them and the strong position that this committee took on reference-based pricing. Next slide, please. Their direction back to FTAC was to continue exploring cost containment strategies and looking at network price caps and hospital global budgeting, which we will be doing today. And then they also approved their 2025 work plan, looking to focus on universal system design during the first half of the calendar year, followed by transitional solutions during the second half of the year. And Mary shared earlier in the meeting that the direction back to us is kind of to follow that same cadence. Roger, do you have a question?
Yes, thank you, ma'am. I was going to wait 10, but the piece referencing on reference-based pricing and the support from the commission, of course, our recommendations on it. And as you mentioned, legislation has been dropped. It's House Bill 1123 and Senate Bill 5083, which is the enabling legislation put forward by the Healthcare Authority on reference-based pricing. And I guess my question back to our FTAC members, might it be appropriate for us to make a recommendation back to the commission for them to write or submit a letter of endorsement for that enabling legislation and conceivably, be prepared should the opportunity present itself to testify in support of that legislation?
It's kind of what we did at the last meeting. I don't have my slides or notes in front of me, but I think I actually read our recommendation word for word to them, which I don't usually do, because I wanted them to understand that, the position was strong. And they did know that there was legislation introduced, and even so, they chose this tack. Now, it doesn't prevent us from coming back and saying, "Are you sure you don't want to specifically endorse the legislation?" And I would be, I'm not opposing that at all. I just wanted to point that out, that we did have that discussion.
Well,
I don't, go ahead.
So to time appropriate, I would like, maybe we could bring that issue up again.
Yeah, or we could, this would be the appropriate time, I think. Gary?
I was just going to say, I think that the discussion at the commission had a lot to do with the recognition that through the legislative process, proposed bills tend to change, and that the details of this matter a lot. And there were some questions that were raised about what would the impact be of adopting this policy? What would the effect on revenue for providers, particularly for hospitals, be, et cetera? And so I think there was a reluctance to take a position on the particular language of this bill, as opposed to supporting the general concept of adopting reference-based pricing without necessarily agreeing to the particular language that's in the proposal. So I think, Roger, my sense would be that as the legislative process continues and things solidify a little bit, there might be another opportunity for the commission to take a position in favor if they choose to. I think now is going to be a little still premature. That's just my sense from the conversation that was had at the commission meeting.
All right.
I tend to agree with that, although what these dialogues give us an opportunity to do is, because we did have this discussion, Roger raised it. I think David will be going back to the commission next time, but he can convey that this was discussed, that there's still a lot of interest in this topic in FTAC, and that that we're interested in the commission continuing to play an important role here. However you would want to say that.
Okay. And Pam, one other quick comment. I listened to that presentation and the results as Gary articulated. I mean, the one issue, I'll be brief on this. The one issue of concerns raised by Commissioner Schmidt, which had to do with rural hospitals in particular, they didn't answer the question. This bill will very much take care of rural hospitals.
Yes.
So
Yeah.
his concerns, quite frankly, this bill supports rural health care, ironically. And I know he was the one member that was expressing concern. I understand the bill can change over time as the legislative process, but again, I would encourage, this is a powerful first step for our state to try to move forward what Oregon has been doing very successfully. And we're talking about cost containment. Here's one right before us. So I guess I would encourage us to try to again encourage the commission to reconsider and conceivably make a stronger recommendation.
Does anyone else on FTAC want to weigh in or offer comments?
Yeah, I just didn't raise my hand, but I would echo that sentiment that we should weigh in and strongly endorse the use of price caps and other rate setting mechanisms to control costs, spending prices.
Thanks, Bob. Does anyone disagree? David?
Bam, I think it's a really interesting idea. I'm just thinking through protocol whereby, the commission asks us to study certain things and to present opinions, which I think we've done effectively. Going back and asking the commission to take a stronger stand than they have come, determined to do on their own, feels like it might be stepping out of line in terms of our charge. So I'm curious, do you have any context for that?
For me, I think it's I'm thinking about you and your new role because you'll be having these conversations. I think that there is, as long as it's respectful and deferential to, they are the authority over us. They are the ones, they instruct us what to do and we help them out. As long as it's respectful, I think they welcome hearing the views of this committee, but knowing and being very clear that these are their decisions to make.
Yeah.
We're there to help them. I think what I would note is that there is more, kind of industry experience and technical experience on this group than there is on the commission group. And so therefore you're sort of speaking from your experience, offering those points of view. But I think it's really important that the dialogue happen, with a great deal of respect and an understanding what the roles are. And really it is to them to ask us for help versus us to tell them what to do. We just recommend what we think they should do.
Yeah, got it. Because overall, I think.
Go ahead, David. Sorry.
Oh, sorry. Can you hear me?
Yeah, go ahead.
I think this is a great place to start from a cost containment standpoint, given that Oregon has already done it, as Roger said, it's proved out there. It feels like a bit of a stretch to say to the commission, you should therefore then be prepared to provide testimony to the legislature on the topic. What'd you say, Roger?
Something like that.
I said they can write a letter.
Or you could also say, consider taking a stronger position or consider what, and it just goes along.
No, I think I got it. I think I can figure out how to present this conversation to the commission in a way that reflects, Roger, what you're suggesting, and Bob, your endorsement of that.
Mary, do you have some good staff advice for us at this point?
Well, I don't know about advice, but at least a staff update of what the staff has been up to. We're talking about the next commission meeting. And what we are working on right now, I'm not going to make any promises that we can pull this together, but our hope is to have some Oregon folks there to provide feedback on Oregon's experience with reference-based pricing. Also invite in some folks who can talk about rural healthcare in Washington. We're trying to put together a panel. This is still squishy and being formulated of what we will ask. And I'm bringing this up just to say that the commission is still looking at this and still considering this. I mean, they may not take a stronger position on that particular bill that is before the legislature, but they are certainly continuing to consider various cost containment mechanisms and rural health and other states' experiences.
Good. Roger.
Mary, I would recommend if you're considering that family of presentations to also include a presentation from our own Welcome Healthcare Authority and our Health Benefit Exchange on the success, its reference pricing with the public option that has yielded, I think Pam will testify to some significant impact on downward trends available in the exchange. So, I mean, we have two real examples, one in our own state with the public option. We're national leaders in that. And, Oregon is a national leader also for using a reference-based pricing model for 7 PEV employees. So that would be the other one you might want to bring into that presentation. And it's a long session, so they can have that. But again, I would encourage us to give some support to our commissioners to endorse it.
Yeah. I would like to take a moment just to thank Bob, who sat in on the last meeting. And as we started to flounder on some of the more complicated questions that we got on reference pricing and other issues, he was able to weigh in and did a lot to help the discussion. And I think it's an ongoing conversation. I think they're going to remain deeply interested, and there'll be a lot of sharing of information between our two groups.
And just on that point, Pam, I don't want to intrude or anything, but I'm happy to participate in future commission meetings as well, if there are questions that come up about payment models and so on and so forth. So just, you can pass that word along if somebody, been interacting with Todd, but I'm happy to participate in the future too.
Yeah, thank you. That's great. Okay, I think that was a really good topic. I think I have one more slide, which is just given there's a lot of interest in the next commission meeting, this is when it is. And as always, you're welcome to sit in on these meetings, and then they're always taped, so there's always the possibility to go back and listen to parts of the meeting that you would be interested in. And I think that's my presentation, unless there are any further questions. Okay, I think we are now, Bob, I think we're back to you. And we're going to hear a presentation from Bob Murray on global budgeting.
Should I share my screen?
Yep. And if you can, I was going to say, just if you make sure you say replace current share to share your screen, and then we will be sure to record it. So I think that's a share option when you, but yes, please share.
Okay, well, I see just one. Can you, wait, sorry, stop share. Let me see. I'm trying to share my just my presentation. All right, can you see the presentation?
Now we got it. Yep.
Okay, great. Okay,
Thank
let me get into presentation mode here. Also, I'm not going to be, well, I can see on the side. So if somebody has a question, please stop me or interrupt me if I can't, if I'm not responding to you guys raising hands. Anyway, well, thanks for allowing me to discuss these topics. They're kind of near and dear to my heart, just because I've worked in these areas for the last 30, 35 years. Just very briefly, overview, just provide some background about me, provide some description, general information about global budgets. That's what the topic, the presentation is. I'll do a simplified example of a global budget so you can kind of touch it, feel it, see how it works generally. Talk about past applications of these models, the objectives and incentives, pros and cons, and then various modifications to address model weaknesses, and then finish up with discussion about governance and oversight. I share the view of Aaron that governance is very important, but I think what's equally important is also for any sort of insurance expansion is cost containment models, government-run cost containment models to make sure that the expansions are affordable. Very briefly, my background, a BA and MA in economics and also an MBA from Stanford. I worked for a period doing consulting for those companies, but then I had an itch to move to the public sector. And there was a deputy director job that was open at the Maryland Health Services Cost Review Commission. That's the regulatory agency that regulates the all-payer hospital system in Maryland. I was there for a while. We did a number of interesting things, most interesting of which I think was the implementation of global budgets. They were fixed global budgets, and I'll talk about the differences between fixed and variable global budgets a little bit later. And then since I've been working as a consultant and also doing some writing health services research. So I just wanted to start with some personal biases. I think, and I've expressed this before, both to you and also to the Healthcare Commission, and I'm also involved in the Minnesota Universal Insurance Initiative, and I've expressed this view too, that any sort of expansive insurance has to be accompanied with a better cost containment system. We saw this. I mean, if you don't have it, then it will undermine the affordability of expanded insurance. You've seen this in Vermont with their single payer. Governor Shumlin, the former governor there, is on record on saying that what killed their universal healthcare initiative was the fact that they had no real substantive cost containment in effect. I also think that the Affordable Care Act is vulnerable because it too did not have any really substantive cost containment initiative after the public option was killed. We've seen that private payers and antitrust activity have not been successful in constraining healthcare spending and price growth. You see a multitude of reports from RAND, from the Congressional Budget Office, from Urban Institute over the last 5 to 10 years that have talked about of all the various cost containment approaches and strategies out there. Only rate regulation really has the potential to constrain costs, prices and spending to a significant degree. You get things like transparency and pro-competitive types of initiatives, but those generally have not been successful. And that is why I'm an advocate of rate setting. We'll also point to the fact that virtually all developed countries have government-run mandated price setting programs that payers and hospitals are mandated to participate in. And I don't think it's any coincidence. That's the key reason why their healthcare costs are about half ours. We don't have that for the private sector. So I also advocate implementing lower intensity, less complex models. These rate setting models are vulnerable to regulatory capture and failure, which I can talk more about later. So the simpler approach, the better. And I've advocated an approach along the lines of what David had mentioned, price caps initially for state benefit programs, moving into price caps for out-of-network hospital care, which has an impact on in-network negotiated prices. It'll allow insurers to leverage up their market power for negotiating in-network prices, and then eventually hospital global budgets to contain costs more broadly. Past global budget applications widely in Canada, less widely in Europe, but France and Germany have global budget models. They both initiated more fixed global budget models, as did Canada. A fixed budget model is that you set a budget for the hospital. That's all the revenue they get during the course of the year, no matter what volume does, up or down. I'm going to advocate a more flexible budget approach that pays on the basis of hospitals' marginal costs, but that gets a little bit technical. I'll go into that later. Maryland's original payment system, ironically, had a system of flexible hospital budgets from 1976 to 92, and Maryland performed exceedingly well, both on growth in per case hospital costs and also per capita hospital costs during this period of time. And I think it's largely because of the use of these flexible budgets, which I'll go into. Rochester, New York, and the Finger Lakes implemented two demonstrations in the 1980s, and they also implemented flexible global budgets, and they were very successful systems. So I'll talk a little bit about that experience. In 2009, when I was still at the commission, we implemented 10 fixed budgets for rural hospitals. The reason why we implemented fixed budgets for the rural hospitals is we didn't really remember back to the success of the earlier flexible budget system, but also rural hospitals are smaller. They tend to have higher proportions of fixed costs. But again, even after that experience, I'm not an advocate of fixed global budgets, and we'll talk about that. There's, of course, the CMS and the Center for Medicaid Innovation. They have a program. The acronym is AHEAD. I can't tell you what that stands for, but that they are promoting states moving into global budgets nationally. But I think there are a lot of issues with that program. And the states that are participating in that have been approved in Maryland, Vermont, Hawaii, Connecticut, Rhode Island, and several down counties in New York. So general characteristics, it's a regulated model. It's not a voluntary model, where a government would establish, as I said, either the fixed or a semi-variable budget covering all hospital services. The budgets would be based on historical revenues. Even if a hospital has been extraordinarily high in their prices and revenues, it's just much easier to start with a historical revenue base. It proves they can live under, if they've been making profits previously under the historical revenue. And you can't go in and give hospitals a big haircut in a given year or raise hospitals' budgets that have been low in a given year. It has to be done gradually over time. The global budgets, as I said, have to be mandated by a regulatory authority. Now, I advocate the use of a public utility governance model that's very similar to the way Maryland had operated with their commission. We can go into that at the end if we have a few minutes. So the state has the legal authority then, have to pass legislation to actually set the global budget and then control the growth of the global budget over time. Presumably it would be targeted to achieve whatever the state's affordability spending growth targets have been. It is really not only best if the models are applicable to all payers and most or all hospitals. It's really kind of a necessity. You can't have a system where some payers are in, some payers are out, or some hospitals are in, some are out, unless you have it on a very kind of isolated regional basis, because you create distorted incentives. Some hospitals are under fee-for-services, they're going to churn volumes. Some hospitals are under global budgets, they're going to restrict volumes. It just doesn't make sense unless everyone's in and participating. Now, to get Medicare and Medicaid in, you'd have to negotiate a Medicare waiver. For the commercial sector, private sector, you basically just have to pass a law to require their participation, the insurance, the commercial insurers. Generally, these budgets will cover just acute care facility, inpatient and outpatient services, but you can also add physician services such as hospital-based physicians and some post-acute and home health. Excuse me. They're a more comprehensive cost containment model than these reference-based pricing models that we've been discussing, like for the state benefit and public benefit programs. But they are still less complex than trying to set price caps on every service for all commercial payers, or the kind of the original rate setting models were more of a kind of a Medicare set a price for each individual service type of model, and then increase the rate of growth of those prices over time. Setting aggregate budgets and enforcing compliance for hospitals of their aggregate budget is a simpler approach because you're focused on one number for each hospital. And that's where the regulatory compliance hits home, is for that one global budget number. There are different approaches. I said these fixed budgets are semi-variable. We'll talk about that a little bit more. And again, I want to emphasize that this model is, I think, a lower intensity model than most other types of rate setting methods, and I think more effective because it controls both price and volume. So the things that global budgets can achieve, again, primarily both price and total spending growth constraint, which are sort of the name of the game. This model sort of replaces or removes fee-for-service incentives that hospitals currently face. And we'll talk about the mechanics of that, but fee-for-service incentivize providers to increase their volume because they can generate more marginal revenue than what their actual marginal cost is when they produce a new service, and that money drops to their bottom line. So that's why hospitals churn volumes. So to reduce the incentive to provide unneeded care also reduces the need for pre-authorization or other mechanisms, denial of care. And so you move to this type of model, and then hospital insurer CEOs could breathe more easily because there'd be less tendency for them to be assassinated. This model encourages initiatives by using savings generated by reducing unnecessary care and then incentivizing the hospital to redeploy those reductions in cost into investments into population health and primary care services. That was kind of the hypothesis, the basis of us moving towards hospital global budgets in Maryland. They also provide better predictability and stability, financial stability for hospitals. And you'll see where this has been implemented, these models, you'll see hospital profitability increase because there's more predictability. And it also the models involve incentives for hospitals to constrain their costs. And under the current fee-for-service, open-ended private sector financing system, there aren't those incentives for hospitals to contain their costs. So you can facilitate a transition of small rural hospitals because it supports them financially, and then even it could be a mechanism to reduce their service capacity and transition them out of acute care delivery into something that is still necessary for community. It also could allow improved payment equity. The regulatory agency could tier the budget updates so that lower priced struggling hospitals could have higher rate increases or budget increases, and those that are higher priced hospitals that are making good profits could be given a haircut and have lower overall rate increases. So the model could improve pricing equity over time. Because of the big disparities in pricing, it will take a while, but that's something that this model could achieve. The model, particularly the flexible approach, can support other value-based care initiatives like ACOs. And I can go into more into detail about that later if you'd like. In Maryland, we modified our global budgets also to include a pay-for-performance quality incentive program as well. One of the negatives about global budgets is they could induce hospitals to restrict care, restrict services. So it's good to have an additional incentive program to encourage that they maintain or improve their quality over time. And I also think these types of models could be the basis of a more expansive population-based system, which gets a little more complicated, but I can discuss that. Here's a simplified example of a global budget. Here's Washington County Hospital in the center of Maryland. Had a budget in the prior year before implementing going to a global budget of $250 million. So we start with that amount as their base year, and then we update that amount. So we start at 250, and then the commission would update that amount from the base year to a performance year by trending for cost inflation, input cost inflation, and then also adjusting for changes in the demographics of the hospital service area. If population's increasing, population's decreasing in terms of their age profile, demand for hospital services will increase. So you'd want to reflect that in the global budget itself. So you get a new budget in the performance year. And then if the hospital can reduce its costs, they can improve their profitability. And I just show this as a random example here, but this is precisely what did happen and has happened in Maryland. And then if hospitals can be incentivized to reinvest those savings in population health and primary care, it can help perpetuate this type of model moving forward. You see, it's just an example. Now, that's basically what was done in Rochester and is being accomplished to maybe a lesser degree in Maryland currently.
Hey, Bob?
Yes.
Mr. Roger,
Yep.
Can you?
Yeah, I can hear you.
Okay. The example you used in there, that includes both inpatient and outpatient?
Yes. Yeah.
Okay.
So the services that we covered, our authority in Maryland were in acute care, inpatient, outpatient services. But as I said, theoretically, you could add other services. I think adding hospital-based or hospital-employed physicians to the global budget can help because you can align the incentives of the physicians that are participating with the incentives of the hospital.
Gotcha. Because just very briefly, because wasn't Maryland's early experience kind of focusing originally on inpatient, and what they saw there was, trend looked good, whatever, but a growth on the outpatient side. I mean, it was occurring for a variety of reasons, but it certainly kind of creates that incentive.
Well, more recent, when we implemented global budgets, they covered both inpatient and outpatient. But what the fixed global budgets did, and I'll talk about this, is they tended to incentivize the hospitals to shed care, to get it out of the hospital and get it to freestanding ambulatory.
Gotcha.
That was the dynamic that occurred. But the problem with that is payers pay for it twice. Then they pay for it once under the global budget. When it shifts out, they pay for it again. So I think that's a negative of fixed global budgets because they provide strong incentives for that. Now I'll talk about that next. That's a good segue. Thank you. So there can be these conflicting financial incentives if you don't have everybody in participating. I don't understand why the CMMI market or initiative is not just kind of creating or characterizing their initiative as a mandated model with everybody in and requiring states to pass legislation to bring everybody in because it creates problems unless you have a contained area. You can't really do this on a helter-skelter basis. It could be done regionally potentially, but not, some hospitals in, some hospitals not, or some payers in, some payers not. So I just wanted to emphasize the mandated imperative of this type of model. Also, I think, as I've mentioned before, fixed budgets have too strong a set of incentives for hospitals to reduce service provision and stint on care. It had resulted in increased wait times for elective and ED care in Europe. In Maryland, the ED times went through the roof. I don't know about elective care. I haven't seen studies on elective care, but it's pretty much a given. If you implement fixed budgets, you're going to get stinting of care and this shifting of care to unregulated centers. Now, it's not bad to get out of the expensive hospital to the unregulated, less expensive, unregulated physician sector. But the problem is, as I say, you pay for it twice because it's under the budget initially, and then when it shifts out, payers will pay for it again. So that's a double payment issue. Now, the other thing is fixed budgets are not responsive to volume shifts. And also, there is still, even though market failure exists and hospital markets don't work very well, with fixed budgets, hospitals have no reason to compete against each other on the basis of quality or service. So I think fixed budgets are anti-competitive, whereas flexible budgets, they can compete for additional volume and they get paid for the marginal cost of that additional volume. So I see fixed budgets as anti-competitive. I think they create significant financial risk for hospitals. We had a couple of small hospitals go out of business in Maryland because they're under fixed budgets, and I think that's another problem. And then with all regulatory models, even flexible budgets are subject to regulatory failure and regulatory capture, and I can talk more about that later. So absolute requirements, everybody's in. Should be overseen by state regulatory agency. It can't be a voluntary thing. You can't get a big payer or a big hospital system to run the regulatory system. Vermont, a couple of years ago, when they did their all-payer ACO, they got the biggest academic medical center in the state to run the system. That's a no-no. It just creates conflicting incentives. It needs to be run by the government. Compliance should be mandated, again, by law, with the regulatory agency having significant fining authority to keep people in line. The agency or commission can have broad powers then of data collection and authority to establish and update the budgets. Those are prerequisites. The agency should be governed by a board of volunteers appointed by the governor. This is the model that Maryland created, and I think is run very effectively. And as it says, it's more of a public service commission, public utility style model of governance. And that model, I think, also has very structural things that can be built in to help protect against capture and failure. Now, the key objective is this controlling costs and spending. This is the Maryland experience. We were growing at 5.97% per capita. They set a hard ceiling of 3.58%, and in the initial years they outperformed that. This is also was in the HMA study that the Department of Insurance commissioned. Showed closer to 2% overall growth from 2014 to 2018, which is quite successful. And as I said, I mean, the other benefit is it can reduce the use of marginal unnecessary services, reducing the need for pre-auth and denial of care, and then you can achieve other goals. I just want to highlight the Rochester global budget model. It's Rochester, New York. There were 9 hospitals in that region that were under a community-wide cap, and each hospital had their own global budget. They were under, again, more of a flexible global budget, so they got paid for a portion of their additional volume. The other interesting thing about this flexible approach is that it has a very stabilizing effect on hospitals that are losing volume, because the model in Maryland, and this is what I advocate, would provide for payment of the hospital's fixed costs when volumes decline. And that's a stabilizing element that can help hospitals that are losing volume remain viable over time. And then potentially the state could decide to transition them into a non-acute facility. But that's what this flexible global budget does. So from that period, from 1980 till 87, during the period the Rochester program was in operation, it really contributed to a flattening out of insurance premium trends over time, and just dramatically outperformed the rest of the nation, and even outperformed Maryland during that period of time. It stabilized commercial insurance premiums. It also was very successful in integrating certificate of need and facility planning in with the whole financial side, because the agency that was operating this had responsibility for both CON, facility planning, as well as hospital budgets. The other thing I'll mention is that it can stable and improve finances. of a hospital. You can see here all the hospitals in New York were bleeding money under their rate setting system, except Rochester. And Rochester actually had improvements in their financial performance under global budgets, but they had better cost containment, interestingly enough. Again, if you can incentivize hospitals to reduce unnecessary care and also be under a constraint finally across all their services and all their payers, they can actually reduce their costs. Trust me, I've seen it in Maryland. Global budgets can also incentivize hospitals to reduce, as I said, low value, unnecessary care. And in fact, in Rochester, that's what occurred. We saw a pretty large reduction in use during that period, 79 to 84. And that's because they were incentivized not to do unnecessary services. Now, there are two versions, these fixed global budgets. As I said, they were used in Europe, Canada, and also in Maryland. They set a fixed amount. There were some adjustments for demographic changes of patient service areas of the hospitals, but basically, it was a very rigid model. So it's very strong, I think excessively strong incentives to manage care, restrict volumes, and shift services. There, as I said, some adjustments for demographic changes, and it also, the model protected Maryland hospitals during the pandemic when there are big drops in volume. They maintained their revenues during that period of time, which is a good thing. But evidence really shows, and I think evidence shows in Maryland, that there are some, as a dark side to fixed budgets, which is stinting on care and shifting care. The Maryland system met its waiver test, but did not meet its total cost of care test because care shifted out, and Medicare, which is the basis of their total cost of care financial test, saw prices and revenues actually increase because they increased on the outpatient or non-hospital side faster than the reduction in savings generated on the hospital side. So there was that double payment. We also found that the academic medical centers didn't like the fixed budgets because it really reined in their ability to introduce new drugs and innovative treatments. So I see that as another negative. Now, flexible global budgets, I said it was a model that was pioneered in Rochester and Finger Lakes, also in the early Maryland rate setting system. It's that middle ground between the 100% fixed and the 100% fee for service model, which encourages overuse. Budgets will then also provide revenue on a marginal cost basis as volumes increase, but it will support hospitals' fixed costs when volumes decline, which is something that's very important for small hospitals or hospitals that are in underserved areas or rural areas. So again, an emphasis on cost containment, but there's a nearly equal emphasis in this model on improving hospital financial condition. And in Rochester, Maryland, this is exactly what happened. It got good cost containment, but also saw improved financial stability and improved financial performance over time. And adequate funding for new technology doesn't encourage shifts or stinting of care. And as I said, I think it's more of a pro-competitive approach to the extent that hospitals can sort of compete on the basis of quality or service provision or amenities. They can gain more volume and they're not penalized for it. Now, the weaknesses, I talk about fee-for-service, which is the other extreme, and why fee-for-service systems produce or incentivize hospitals to produce unnecessary services. It's because they're paid 100 cents on the dollar for every new case, every new test, every new service that they deliver. This is in the context of hospitals having both fixed and variable costs. Fixed costs are in their base and they're funded as long as volumes remain stable or increasing. But variable costs are generally, and this is based on studies we did, and also observing hospital management decision-making, are in the range of about 50 to 60% of average costs. So you have a system where under fee-for-service, you're getting paid 100 cents on the dollar for every new service when your costs are only 50 cents on the dollar. For all new services you produce, that excess revenue, marginal revenue over marginal cost drops to your bottom line, and that's why fee-for-service incentivizes unnecessary use. And so that's the key element of this. It's handled through something we refer to as the volume adjustment system, which paid on the basis of marginal cost for volume growth, but then supported hospitals' fixed costs when volumes decline. And so hospitals will get a bump in their budgets as volumes decline to make sure that they were covering their fixed costs. Under fee for service, you get this over rewarding of hospitals for providing unnecessary services. And so you get I think some studies are showing anywhere from 600 to $900 billion a year of unnecessary care is provided, and the volume adjustment system under a flexible global budget can correct this. Just to show you these extremes, I mean, fee for service, we've already talked about that. That's you're paying 100 cents in the dollar for each new service. The other extreme are fixed budgets. As I said, Maryland isn't 100% fixed, but it's largely fixed. And so you're getting basically zero for additional revenue. And this approach that I'm advocating is a middle ground approach where the hospital will get paid for their variable costs for volume increase, but also support their fixed costs if volumes decline. The mechanics, people really debate about what are the proportions of fixed and variable costs. MedPAC thinks it's like 80% variable, but that's based on long studies over time, over long periods of time, when basically, over the long term, we're all dead and variable costs are 100%. So, but during the course of a decision-making period, like a year, fixed costs and variable costs are more like 50-50. And as I said, the Maryland system worked extraordinarily well under this assumption, 50% fixed, 50% variable under the volume adjustment system. So under this type of model, if volumes were to go up for a hospital by 1%, their increase in their budget would be 0.5%. So it's a kind of, again, that middle ground approach. It would fund the variable costs. And then a hospital experiencing a 1% volume decline would have revenue declines, but it would be paid 0.5 more to cover their fixed costs as volumes decline. And as I said, it added a lot of financial stability for the hospitals, particularly the smaller rural facilities, as they saw their populations age and reduce and volumes reduce over time. Hospitals report a fair amount to the commission. Commission adjusts their rates on a monthly basis to make sure they're in compliance. And then there's a settle up at the end of the year. But again, the focus is on one number, their overall global budget number with adjustments for volume changes up or down during the course of the year. And it's important that the agency have authority to fine for noncompliance and also settle up for hospitals. But largely the system was self-regulating after a period of time where hospitals monitored their budgets, monitored their prices. If volumes were going up, they'd lower their prices according to what they were required to do, and vice versa. Volumes going down, they would raise their prices. So at the end of the day, they would be in compliance with their global budget. Key steps, you develop the rate base, use historical revenues, define the services. As I said, it's primarily acute care hospital services, but you can also bring in other physician services, maybe long-term care, acute, post-acute, and home health. Determine adjustments to the rate base. By adjustments, I mean you can actually add supplemental funding for various things, like pay for uncompensated care or reasonable levels of uncompensated care, because that could be another element that can enhance this model. And then also provide seed funding to promote better care management. That's what we did in Maryland. We tried to add some money to the hospital so they could get out there, hire more primary care physicians, and invest more in population health. Next step, choose between a fixed or variable approach. Determine how they're paid for services. I think you can retain the existing payment system. And I've done a little work with David Giuseppe on this. We developed a system in Vermont that retained the existing claims processing system for all payers. So we didn't have to go to a different types of basis of payment and change how Medicare pays or change how Medicaid pays or the private sector. So I think it's important to kind of keep the system similar to the way it's been before, but change the incentives. And that's one way you do that. It's largely a formula-based prospective system, which, as I said, has strong incentives for hospitals to contain their costs. And they have to basically account for what their input cost inflation is. You give them adjustments for demographic change, but then that's it. They have to manage their unit costs. States can also tier the budget updates to try to address payment inequities. I mentioned that earlier. And the regulatory authority has to exercise its legal authority to mandate compliance. This is, again, I just emphasize, is not a voluntary model. None of the other developed countries have voluntary regulatory models. They're all enforced by law and regulation. Just finishing up here, this is a little hard to see. It didn't kind of come through in the slide deck that you got, but I tried to look at historical growth in hospital revenues in the state on a per capita basis. They didn't grow much in 14, but then it's more and more rapid in 2015, 6.39%, and 2 to 4% or higher since that time. And so you also looked at non-hospital service growth. As I said, as you clamp down on the hospital side, there's a tendency for hospitals to shift care, so you want to keep your eye on that as well. We look at the population. And so I just did a kind of a back of the envelope simulation similar to what HMA did, and said that if we had historical growth at 2.93%, if instead you had growth at 2.5% mandated by the global budget model, you could actually generate savings of 1.7 billion over this period of time. I think this is 7 years, 6 or 7 years. So, and again, hospitals are big drivers of overall price and spending growth. Interestingly enough, Washington's hospital prices and spending hasn't grown as rapidly as other states, but don't use that as something to give you confidence that that trend will continue. I think that hospitals continue to consolidate and increase their purchasing power relative to private sector, and so it's good to cap them over time. Final observations. Incentives are the name of the game. You need to change the incentives. I think you can also scale back the need for pre-authorization or denial of care under a model like this flexible global budget model, which removes that incentive under fee-for-service to do unnecessary care. And then, as I said, the concept in Maryland was if hospitals can reduce costs, generate savings, they can redeploy those savings into population health and improved care management activities. Hospitals are generally not good at doing that, but that at least is an option for the ones that are more progressive. And over time, I think they gravitate towards that. The big issue here in this market or this industry is market failure, and in particular, structural market failure. The fact that hospitals have muscled up, they've consolidated, and private payers are really not in a position to negotiate effectively. So you need regulation, avoid regulatory capture and failure, and also try to focus on simpler models, and develop structures like a public utility model, which I think can help avoid these key issues, regulatory capture and failure. So I see a couple questions or hands in the air. Let me just stop here for a second and ask Roger, you have a question. Yeah, I think you're on mute, Roger. I can't hear you.
Bob, thank you very much. Can I rattle through my questions and then we get whatever later on? So let me just go through them very, very briefly. Just two observations about Maryland. One is, you know better than I do, it is a resource intense operation. I mean, my understanding is they have a staff of about 45 folks to run that system. Well,
you don't need that.
Well, I'm going to say that's what they're showing.
Yeah, but that's I said there's this. So I sort of cut you off here, but there are simpler ways of approaching this, not over the top ways. So you don't need that. You need for state of Washington, you need maybe a commission of staff of 20.
Okay, all right, gotcha. Just one other anecdote, and I'm not sitting here trying to advocate for the state of Washington's hospital system. And I was surprised looking at some expenditure data on hospitals. This is the last 5 years, 16 to 20. I was surprised to see that Washington ranked third lowest.
Yeah. As I said, I'm just looking at the trends from the National Health Expenditure.
Yeah, same thing.
It looked very low. Now you look at Maryland, maybe at that area or lower. Like I said, they have 1.92% for 4 or 5 years. It's fluctuated since the pandemic, but yeah, Washington's been lower.
Sure. So let me rattle through my questions real quick.
Yeah.
One is in these systems, you want to bring Medicaid in.
Right.
I've never quite understood, and you're not going to set rates at a Medicaid price level.
Yes,
So,
you are. You start with existing budgets and existing price levels and go from there. You're not making changes. You can't bring Medicaid, Medicare
well,
up
that
and
was
bring.
my question. You
Yeah,
answered
so
it.
you start with status quo. That's the only way to start a system like this now. Maryland had the benefit back in 1977 of having a system where there weren't these huge differentials in pricing. And then they locked it in. They had higher Medicare payments and they locked that in. You're not going to get a deal like that these days, where you can raise Medicare and Medicaid while you're trying to bring down commercial. So you got to start with status quo and then control the rates of growth from that point.
Gotcha. All right. And then the last one, with terms of Rochester and the Finger Lakes, you're describing them in the past tense.
Yeah.
Are those systems still going?
No, so they ended in 87 largely because it was about the time that IPPS Medicare prospective payment came in, and that system had very generous adjustments for teaching payments. And there were a number of teaching hospitals in Rochester. They looked at the analysis and said, hey, we're leaving all this money on the table by being outside of the Medicare system. And so they trashed their system. And of course, since then, Medicare has ratcheted down on their payment methodologies. But that's the key reason for why Rochester went away and also why several other state rate setting systems went south is because the teaching hospitals said, let's get rid of our waivers. Sorry. How about Christine? You have a question.
Yeah, thank you. This is really interesting and great presentation. I'm just wondering, so is it possible that there's some incentive, even with this flexible system that you described, that certain patients might end up sort of at the short end of the stick? And I'm thinking of like more expensive people, or maybe severely mental ill people with like transplants or something like that, where the hospital doesn't want to take on that new cost because that 50% increase, that's still going to be difficult for them. And then I don't know if you saw that happen in Maryland, and how does the system address that kind of risk kind of shifting?
I wasn't there from 76 to 92. I came a year after they got rid of the system. But it wasn't my recollection that there was that type of dynamic. I mean, it could be where, services that are more variable than the 50% that they're getting, hospitals might look at that and say, we should scale those back. But to be honest, I just don't know that there was any evidence of that in that period, 76 to 92. I mean, I can't swear on that, but the people that were there that ran the system never mentioned that there was that issue. Whereas currently there is an issue with regard to wait times for ED under fixed global budgets. And also, I would believe that anybody did a study about elective wait times, I think the evidence would show that they've also shot up, as they did in France and Germany when they had fixed budgets. So I think it's good enough such that it doesn't. And then, if like hospitals are turning people away, they have bad publicity. So it's good enough to avoid those circumstances, in my opinion. Now, you could make it more complicated. I wouldn't advise doing this, but you could look at services that are more variable and adjust those proportions. But that leads you down the road of regulatory failure where the system just gets too complicated. I think Maryland proved that if you get it close enough to right in terms of the incentives, the system works appropriately. It looks like Eddie has a question.
Yeah. So on your examples that you're walking us through, could you walk us through, so you have your 3% target, and, if they're better than the 3% target, I guess that's profit to them. But on the other side of that, is there some adjustment that happens if they don't meet that, because that would cause a problem?
Well, I mean, you don't want to pass through the fact that they didn't meet their target too. That's a whole half of the point of this type of model is it provides a constraint. So if the hospital's not meeting their profitability goals, then the things that they need to do under this model would be to improve their unit cost containment and reduce their volumes of unnecessary care. And if they don't do that, the profit incentive sort of mandates they do that. So you don't want to bail them out if they're not doing it. And I personally think that hospitals can get by reasonably well with margins of 1 to 3%. I mean, the hospitals in New York lived under negative margins for close to 10 years, and they still survived. Because now that's not the ideal situation, but hospitals don't need 4% margins each and every year. They need 4% margins so they can go to the bond markets to get more financing to go out and empire build. But they don't need 4% margins. So I think there's too much emphasis on, oh, we got to make sure the hospital's flush. You want the hospital constrained, and you need them focusing on improving their efficiency and also reducing unnecessary services. So you got to toe the line someplace. Now, with this model, if there was a hospital that really got into trouble and there are access issues or problems, the regulatory agency could sort of bridge the gap and provide financing, short-term financing to keep the hospital afloat for a period of time. But you want to keep that pressure on.
So no structure built up front like a risk, but just saying.
No, I mean that's an interesting question. I think for smaller hospitals, particularly under fixed budgets, you could do a like a risk sharing, or an aggregate stop loss, or so if they were losing money, you could have an adjustment. But again, that just undermines the cost containment incentive if you have that widespread, and I wouldn't argue for it. If the regulatory agency finds that there's a really sticky issue a hospital can't get itself out of, and there are access issues, they can come in and raise their budget temporarily, give them a loan essentially, and then pull the money back out when they've got their house in order.
And how frequently would you check? Is this every 6 months, every year? Is that?
Oh, well, I think that the whole thing with this system is you monitor it on a monthly basis. So you're monitoring prices and budgets, but you're also monitoring their financials on a monthly basis. You'd have to set up a data collection system so you're seeing their volume, price, and also their financials on a monthly basis, so you can monitor all this stuff over time. But the key is the buck stops with them now, and you got to have incentives for them to manage themselves more effectively, as opposed to our current system, which is an open-ended financing system in the private sector.
Thank you.
Sure. David, my man.
Yes, Bob, thanks for your presentation once again. I think that I've been captivated by your concept since you first described it to us a couple years ago. And my hunch is that if the commission members heard your presentation in this level of detail, they would find the argument and the concept as compelling as I find it, and I think some of the rest of us find it. So where my mind is going is, and I'll frame this as a question to you, but I invite anybody on the call to react. What would it take for the commissioners to get excited about endorsing or recommending to the legislature that this model be implemented? And what I'm thinking is, especially with legislators on the commission, they're probably going the next step and thinking, well, what does the hospital association think of this?
They won't like it.
Who are the stakeholders that are going to get upset by me endorsing something like this?
Yeah, there's just a general anti-regulatory sentiment, and the hospitals will be, if you haven't heard this yet, but as soon as you introduce the bill for reference pricing, they'll be against that. So I mean, that's pretty predictable. Payers might be sort of lukewarm supportive of this. If they understood the incentives, kind of scale back the need for them to do pre-auth and also denial of care. It also makes it easy for them. They don't have to negotiate anything, and they're basically kind of out of their league now because these hospitals are all consolidating, and the negotiations are like, okay, what do you want this year? And the hospital says 8%, or I'm going out of network, and the payer rolls over. So in this case, you avoid that. So I think generally payers would be in favor of it. Labor should be very strongly behind this, supportive of it. Business too, but business is engaged and not very astute with regard to healthcare policy issues and payment. But in general, I think for consumers, this is a very important thing, and to try to stem premium growth, which all flows back to wages and employment. We're financing all these year-over-year increases that way. And under a universal system, you'll finance it out of tax increases. This way, you don't have to do that. That's what Shumlin said in Vermont. He said, we've got healthcare costs going 7-8%, We have an 11.5% payroll tax we have to add, plus an additional 9% to our state income tax to finance the universal system. And then healthcare costs are still going up at 7-8%. It won't work. So you got to get your cost containment business in order first before you consider expansion of insurance. That's my buy-in.
Yeah. So maybe Gary or Pam, this is a question for you. If we as a committee decide to recommend that the commission support this concept similar to what we did with reference-based pricing, do you feel that we would need to provide any kind of playbook for the commission to get comfortable with this, or would it simply be a straight recommendation and let the commission figure out their comfort level with stakeholder reaction?
If I could make a suggestion, it might be worthwhile if they're willing to let me present this model first, just to give them a kind of sense, feel it, touch it, see it. That'd be great. I think the other thing the commission might be interested in, I did a case study on Washington's previous health hospital cost containment commission. I interviewed a bunch of people. I looked at the literature. So, you've been down this road before. It didn't work. I think I have some good ideas as to why it didn't work.
Yeah,
So that might be another factor they'd be interested in discussing.
Yeah. Yeah, that sounds good. I know that we are going to, after break, we're going to come back to kind of talk about principles and how we want to go forward and all these things. And I think that the global budgeting is really interesting because you don't have to wait for system reform to do it. We could, recommend doing it now, or we could see it as kind of a linchpin to system reform because it would save money. So I think it fits in either transitional or long-term, system reform. And I think that my understanding is I think we were supposed to take a break. We're a little over time, but no one was going to say anything because the discussion was so good and the presentation was so great. But to come back afterwards and talk about how we want to put together like a set of principles that we would carry forward to the commission. Is that right, Mary?
Yep, that's right.
Okay.
Excuse me.
Yeah, and let me just mention, I think David could be very useful in this discussion too, particularly since he's the liaison to the commission. David and I have talked about the kind of the mechanics of this model. So he's technically very astute, and so he's understanding sort of how this model works. This is not just kind of a black box thing. You can go through in detail how the thing works for those of you who don't mind brain damage. But so it's not something that couldn't be discussed and couldn't also be boiled down into terms and concepts that most everyone could understand.
Yeah.
And on the other point, also Roger's point, Maryland went after I left for some reason. We talk about empire building in the hospital industry. I think regulators are also prone to empire building. They have far more staff than they need to, and they bought off too much. They wanted to control total cost of care, physician and non-physician. They didn't have the authority to do physician or other services. And so they hired all these extra people to do all this data analysis, and they don't need it. And Maryland is also a much more complicated system because the statute requires that each service price be related to the cost of each service. So they have to regulate individual service prices in addition to global budgets. And I'm not advocating that. I'm saying keep it simple. Let's control prices and spending and leave it there and then address whatever untoward circumstances you identify.
Okay. Thank you. Should we take a short break or should we move right on to the next topic?
I'm fine moving on. I mean, I hope I didn't sort of inflict brain damage on everyone.
No, I think you improved our brain functioning. I already feel smarter. So I think Mary put up the break sign. So why don't we take since we're shorter on time, why don't we take a 5-minute break and regather at about 4:00. And so everybody can just take a stretch and we'll be back in 5 minutes or so.
Thanks.
Okay.
Self tape. It'll make a sound. Okay.
Yeah, that's okay.
Okay. I can
Yeah.
turn it off before it makes the.
Try to, yeah, if you can.
I think we're slowly making our way back, Gary.
No problem.
You never quite know if people don't put their cameras on.
I know. I'm giving people another minute. Oh, it looks like the minute's up. It's now 4:00 on my computer. Let's see. We got Bob back, David. Roger's back. Do we have Todd? Is Todd leading off this next item?
Yeah, but I actually was going to jump in for just a second because we had a new staff member start today, and I was hoping he could do a real quick introduction before we went into Todd's presentation. Does that work?
Yeah, that works.
Yeah.
Let's
Within
go
the health, yeah, the staff that staffs both the Universal Healthcare Commission and the Healthcare Cost Transparency Board, we have a new director, Ross. And you know what? I should have checked to make sure Ross was back. Oh, there we go. Ross, do you want to do a real quick introduction? Jumping
Yes,
in on your first day?
Thank you, Mary. Yes. Hopefully everyone can hear me. Apologize. I had some audio issues initially. So hopefully after the first day, we can get those rectified. But very happy to be here. My name is Ross Valori with kind of a hard E. Very excited to be coming over to HCA. Previously, I was the executive director of the Certificate of Need program with the Department of Health. And very much enjoyed that previous conversation that folks had regarding financing, digging into a lot of the issues that we were very interested in the Certificate of Need world. And prior to that, held a variety of legal staff attorney positions at the Office of the Insurance Commissioner in the Department of Health, and also did some policy work. So really excited to come over here and partner with you folks and hopefully do some great work to identify cost drivers and some of the underlying assumptions we have for healthcare financing. So really excited to dig into this with you folks as I slowly come on board, and I'm available for any questions or concerns, and look forward to getting to meet you in person and discuss these great ideas. So thank you, and thank you for the time, Mary.
Thanks and welcome. And Pam, I think we can move on.
Okay, thanks. Thanks, Ross. Let me get my camera back on. Okay, I think Todd, I think you're going to lead off on this next section, which is how we make sense of what we just heard and how do we carry it forward.
Thank you. Can you hear me?
Yes.
Next slide, please, Audrey. I'm Todd Bratton. I am here from the Healthcare Authority team to talk about cost containment. So next slide, please, Audrey. So just for a couple of minutes, I'm briefly going to describe our team's proposal for helping FTAC meet the goal of developing cost containment recommendations, which will inform the Commission's decisions on universal design. And so I will cover here just in the next couple of minutes our proposal for that design process, the potential for cost containment guiding principles. And then I'm going to turn it over to Gary, who will lead a discussion amongst FTAC members about whether this proposal makes sense and how else the FTAC members might like to proceed. So next slide, please. So the process we are proposing here is that over the next couple of meetings, FTAC work on developing a brief or a memo similar to what has been produced in the past on issues of eligibility with regards to ERISA and Medicaid. In this case, we would help FTAC develop a cost containment memo. And our process for that is twofold. The first part would be identifying cost containment strategies, measures, or policies used in Washington State, used in other states, and used in global systems. And so developing sort of a comprehensive list of these strategies, circulating it amongst members, And for the purposes of helping the commission develop universal design recommendations, we would like to identify any components or strategies that should be included in any universal system. And as we do not have a determination on what that system looks like right now, we thought the first part of a recommendation would include identifying any strategies that sort of any health system would use to contain costs. So next slide, please. So during the discovery and looking into these strategies, which FTAC and the Commission is already doing on reference-based pricing and global budgeting, for example, we thought there might be some guiding principles that might emerge from that discovery. And so this process would proceed in parallel with the strategy process and would identify any guiding principles that would emerge as FTAC reviewed some of these strategies. And so this would proceed in parallel over the next couple meetings, and the Healthcare Authority would help you all revise any guiding principles that you should identify. Next slide, please. To provide you all with an example of what that might look like, our team looked at Bob Murray's presentation on rate setting and reference-based pricing and pulled out a couple of statements that we thought might act as principles. We are not suggesting these are the principles you adopt. We're not recommending these as
Todd, did Todd freeze up, or is it me?
It's me too.
Like it's
Yeah.
Todd.
Okay,
He's back.
Todd, you froze there for just a minute. You might want to back up on this slide.
Okay, pardon me. Thank you. So am I with you? Thank you. So these principles here that we are providing are not recommendations. We wanted to pull out some ideas out of Bob Murray's presentation on reference-based pricing and rate setting and illustrate to you how you might divine some principles based on the information you're reviewing. So these are not recommendations on what you should adopt. We wanted to illustrate how by reviewing some of these strategies, there might be some ideas or statements that FTAC would want to make to the Commission about cost containment that exist alongside of the strategies. So next slide, please. So in sum, this process would include two parts. One is discovery of the strategies and identifying which, if any, would be necessary in any universal system. And the second part would be identifying any principles that FTAC might decide were important to also communicate to the Commission for their recommendations. So with that, I'm happy to take any questions, but our team is here and we can help answer our thought process on that. But Gary is going to facilitate your discussions on cost containment and whether this process makes sense or what else the FTAC members might like to consider as they develop these recommendations for the Commission. So thank you.
Thanks, Todd. And Audrey, next slide, please. So here are some of the questions. What we want some input from you all is whether the process that Todd has described makes sense to you, whether you have any thoughts or suggestions about it, and any other thoughts and suggestions of how we move forward from here. One point I think that's important to note, based on the conversation that we've had so far, is as Mary described at the beginning of the meeting, the Commission has set as a goal for itself for this year to make recommendations regarding how providers are going to be reimbursed under the universal system. So one way or another, some method is going to be necessary, obviously, to determine how providers are going to be paid. And there are a variety of different ways you could do that. As Bob described, one way that would be the most complex would be to set rates for specific services that would be provided, is, kind of in the way that Medicare does, right? Medicare has a rate schedule. Another way would be using the Medicare rate schedule as an example, as a reference, and setting provider rates as some multiple of what Medicare pays. Another way would be to have a global budgeting system that, as Bob described to us today. So one way or another, part of the commission's mission for this year is to make recommendations as to how is provider reimbursement going to work under this universal system. And as a part of that, the commission has also said, we understand we need to do something about cost containment, that unless we manage costs effectively, the universal system is going to be unaffordable. So with those two goals in mind, the question is, how we're interested in input from you all as to how you think you can best assist the commission in accomplishing both of those goals, figuring out what's the method of provider reimbursement going to be under the universal system and coming up with a way of containing costs that's going to make the system affordable. So the suggestion here, as Todd described, is to come up with a variety of different options and alternatives, and then having ultimately the work product, so to speak, of from FTAC be a report back to the commission with your input and your recommendations on what direction you think the commission should pursue. David.
Gary, the first thought that occurs to me is whether cost containment means controlling the trend moving forward, or does it mean realizing cost reductions compared to the current system? And I'm thinking back to what I think was the predecessor to UHCC, the Universal Healthcare Work Group, and I thought that their report had described modulating the fee schedules such that there would ultimately be something like $8 billion in savings under a unified fee schedule, which would be more of the cost reduction approach versus like the hospital global budget concept we just talked about. I think is more about starting with current costs and then controlling the trend moving forward. So do you have any thoughts or context based on your work with the commission?
Well, I think that's a really good point, David. I think that my understanding of the savings that are anticipated to be achieved are primarily based on reduction in administrative expense of running the system, given how complex it is. And, we have so many, different payers, and, we have a lot of administrative costs that presumably would be eliminated if we had a more uniform financing system, as opposed to reduction in the actual cost of healthcare. So whether I think that as Bob described it, and I think this is an important element in his presentation, is we don't, if, for example, under our global budgeting system, we don't start out by saying, hospitals, we're going to cut your historical revenue by 10 or 15% and expect you to live off that. We're going to start with the revenue that you've been earning, and we're going to provide incentives to manage your costs so that cost increases are less going forward than they would otherwise have been.
Got it. So, Gary, are you looking for us to flesh out these principles now, or are you saying that you'll be sending us some materials to review and react to, and that it would be at the March meeting that we're coming up with the principles?
I think that's right. Mary, is that we're going to come back again?
Yeah. We had thought that perhaps we had time to do some brainstorming today, but we're running low on time. So I think what might work better is for the staff to do more digging and more research, circulate a set of principles, with no recommendation and no opinion behind it. And then FTAC members can react to that, and we can go back and forth, and then we can have a set of principles for further discussion at the March meeting. If that sounds okay to FTAC members.
Pam?
Yeah, well, there are other hands in front of me, but that does sound okay. I want to just acknowledge that we've already had a lot of discussion about cost containment, and this is a group with a lot of enthusiasm on that topic. So I would just, to the degree that you can, you've got, minutes and discussions, if you can incorporate what we've already, decided, I think that will give us, a better starting point. I think we can kind of take advantage of, we've been a little bit, hit or miss, the way we've talked about all the different topics, but I actually think it does start to add up to something, and we can start there. I think that would be good.
I think that's a very good approach. Thank you.
Roger?
So I'm going to try to put some things in some buckets. These aren't principles, but to try to summarize some of our conversations on cost containment, etc. So I'm just going to, here's sort of the Roger buckets. I think Bob has given a great presentation on global budgeting. As I look at global budgeting, I think it's a tool to consider. A side note to that, however, is that it's based around facility services, hospitals in this case. You're not going to, I guess I think about doing a global budget for everything in the system, and that's not what Bob is proposing. Another sort of thing that we've talked about and been introduced is reference pricing, which can apply to hospitals or to any other set of services that aren't embedded in that global budget. I'm going to go back to a point that Gary mentioned in the previous work that the work group did on savings for the system. And those, in my view, came in two areas. One were administrative savings associated with a single payer, state administered system, what we've heard talked about. There's compelling arguments around just on the administrative side of that, plus the ability of that system to, if you will, to address trend. These are all kind of interactive in that. Another point I guess I would like us to consider as we go through these discussions, and I think it's an imperative one, that we engage more closely with the Healthcare Cost Containment Board. Because part of our charge is to look at transitional solutions plus the grand scheme, the grand system. Well, the Transparency Board, I mean, they're on the ground doing a piece of that now. My own view would be on that size subject, I think that Bob's presentation before the Healthcare Cost Transparency Board would be great, because they're looking at toolkits, right? How are we going to deal with trend? Well, Bob in the global budget aspect is given a strong toolkit to how to address that. And quite frankly, they're probably maybe in a better position to begin to implement some of that than we are through FTAC or the commission. So my point is an impelling need to have a closer linkage with the Transparency Board. And then the last one, I'll be quiet. I would again ask us to consider. I think we kind of left in that one directionality here. Is there's legislation before the legislature now with strong Democratic support to begin to introduce a step that Bob's talked about, reference-based pricing for SEB and PEB. And I guess I would encourage us, our group, to make a stronger recommendation, David, you'd be carrying this one, back to the commission to actively support that legislation. And I'll just say this, if we can't get that through this legislature, right? Global budgeting isn't going anywhere because we need enabling legislation, right? And if our state doesn't have the what am I looking for? The appetite to take on what Oregon has done, then we have a real challenge before us. And the only reason I mention that is because legislative enabling legislation, as Bob has pointed out, is critical for a global budget or any of these other cost containment strategies. So
Bob, I see you have your hand up. I want to ask a question that I think stems a little bit from Roger's comment, which is how do you see the relationship between a reference-based pricing approach and the global budgeting approach? Because one of the characteristics of the global budgeting approach that I think I understood you to say is an advantage is you're not telling the hospitals how much they can charge for any particular service. You're telling them, here's your budget, you live within it in whatever way is best for your institution and your market and what have you. So that if you can be more efficient in one area of your operations, you can save money there. And we're not telling you, you can only charge X percent of Medicare for any particular service. So I'm interested in your question, if your whatever your question or comment is, but also how you see the relationship between those two policy approaches.
Y'all try to adjust your question first and then go to the comment I was going to make. I think with the global budget system, the way I've outlined it, it really reduces the need for a reference-based pricing system. Nothing's certain in life except death and taxes, and so whether you could get through a reference pricing bill or not, I don't know. But I think global budgets would could have the potential to control both price growth and overall spending growth. So it sort of obviates the need for a price caps program reference to Medicare. Now you could have that in addition, for certain agencies like OEB and PEB. In addition, but it's a little bit redundant. So I don't know that you need a complex or potentially more complex system like a reference pricing system, which is at the individual service level if you have global budgets. Now, having said that, the commission that's regulating the global budget system has to be able to collect a lot of data and sort of sleuth through the data and make sure that the hospitals aren't doing things to game the overall the flexibility with the global budget system. So it's not like, as soon as you set global budgets, your task is done and you can walk away and have a cup of coffee. You really still have to focus in on how hospitals are responding and what are sort of the untoward behavioral responses to it. So, but I just recommended reference-based pricing because it's easy. And Oregon did it and said they kind of a proof of concept. And it gets a state down the road of a regulatory strategy.
Right.
And just
you had a comment.
Yeah, just my quick comment. I mean, you mentioned about administrative savings. I sort of missed the beginning of your discussion there. I'm assuming that was in the context of an overall universal system. I just wanted to make mention that I always suspected that the rates system in Maryland reduced administrative costs for the overall hospital system. The reason I mentioned the hospitals and payers don't negotiate. Things are more standardized. You don't have pre-auth and denials as frequently as you do in other systems. So there are a variety of things, and also we have this very fragmented system, so this homogenizes things to a certain extent. I never really saw any studies that prove that point, but I saw a reference recently to a study that concluded that Maryland had 9% lower overall hospital-related administrative costs because of the rate-setting system and the global budget system. So that's another benefit of the model that I'm recommending. So I was just going to make a plug for that.
Dean? Whoops.
Did you call on someone, Gary?
I tried to call on Christine.
Okay. Yeah, Christine, you want to talk yet?
Thanks. Yeah, I just wanted to, as we consider this exercise, I think it'd be helpful to think through a little bit more. What of these policies would be sort of transitional and what would be after the universal financing system is implemented? Because I can see that some of these things don't make as much sense with universal financing. And I'm just not clear on when we're having these discussions, whether we're thinking that through fully.
No, I think that's exactly right. Yeah. Pam, you had a thought?
Yeah, I felt compelled to note that the reference pricing bill that you keep referring to is not like a system-wide bill. It's very small. It's basically just targeted to the employees in the state, healthcare system under PEB and SEP. So it's not like, it's not the pathway to global budgeting. It's very different. And it kind of gets to Christine's point, which is like, we just get some clarity between what are we talking about transitional reforms versus what are we looking at for system-wide reforms.
No, and I think that's an important point, but I guess, the work group assumed in its projections of what the system would cost, it assumed a uniform rate that was going to be higher than what Medicare pays and lower than what commercial pays today. So it kind of had baked in
right
a reference-based model.
Right.
And I think an important question for you all and ultimately for the commission is that direction that we want to go in, or do we want to go in a direction that's more like a global budget direction, which is different? Those are decisions that need to be made in the design of the uniform system, as well as anything that we might do as a transitional solution, like the PEPSET bill, as an example. Right. Roger.
Yeah, I think Gary, you captured, the point I'm trying to make. Let me back up on one of the things that Bob was saying. When I was kind of putting things into buckets, I don't see these as either or. I'm just trying to use a simple example to say is global budgeting, which is a great model, deals with the family of services associated with what hospitals deliver. There's a lot of stuff that's on an outpatient, et cetera. Pharmacies, a good example, patient pharmacy, et cetera, where one can make an argument that a reference-based pricing tool would also complement what you would do likewise for global budgeting for those family of services that are not otherwise, are not delivered in an inpatient or outpatient hospital setting. So I'm not trying to pit them one another. I'm saying, and my only other point about harping back on this reference-based pricing one is, and I think Pam covered it, we need to be real about transitional options. We have a transitional option before us. Again, with what's being proposed in this legislation, I keep coming back to that I would encourage us to want to support it. It's getting our foot in the water in this critical area. So I've said, no said.
You're on mute.
Thank you. Hello, I just wanted to, for the purposes of this exercise, what we hope to do is identify strategies for universal design specifically, as the commission is looking at the design topics in the first half of this year and the cost containment. So just to list a couple of cost containment strategies that might be included in the universal design system, such as utilization management, such as cost sharing, and those things that are in most universal systems. And so it may be a sort of a tedious exercise as we send these strategies out, but I think the commission would benefit from hearing from FTAC, what are the mandatory cost containment strategies for any health system? So that was the purpose of our exercise here. And so that's where we were hoping to lead off with.
That sounds good.
Mary, you want to wrap us up?
Yeah, thank you very much. Pam, I'm just going to jump ahead to what is the last tab. And Audrey, we don't need to go through the slides. It's talking about benefits and services design. And we're just going to spend a few minutes, and I'll only spend about 30 seconds at the very end of the meeting, reminding people what's done in the past. Also just reminding that this is a priority for the commission in 2025. So the slides are really mostly reference. It talks about what the work group said, includes the ACA, essential health benefits, and the Washington benefits. And it's where we're going to get started once we jump into that topic. So thank you. Feel free to review the slides. No need to go through them now.
And we will be turning to this when we get back the Milliman report on the cost differential among the various benefit designs that they're looking at. So essential health benefits, Medicaid, and what's offered under PEPSET. So we'll have an opportunity to see what those cost
Right.
differences are likely to be.
Yep. The next time we come together, we will have that information. So we'll dive in a little deeper.
Okay. So next at our next meeting in March, sounds to be a robust meeting we're planning, and we're going to dive into the cost containment issues at a much deeper level. I think we can expect homework between now and then. That's what I'm hearing. So thank you for that. I presume that if people have questions about their homework, they can direct them to staff in the short term. And then at the Universal Healthcare Commission, David will be presenting, summarizing this meeting with a lot of encouragement about listening in on the global, maybe setting up the global budgeting discussion for that group so that they have an opportunity to learn more about it. I would note that despite Roger coming in, Roger, I say this with a lot of affection. I think you came forward 4 times asking for UHCC to formally endorse the bill. I think that I'm not sure that the whole group had that request. So I just want to make sure that, David is clear that he can convey that there was deep enthusiasm in the group to do something on this, and that, overall there continues to be really strong support for reference pricing and transitional solutions that include reference pricing. I hope that was clear. I was just trying to find the balance in the different remarks from this team. And I think that wraps us up for today. This was a really, really good meeting. Really appreciate the presentation from the Health Transparency Commission. That was great, but also Bob really made an important contribution today to kind of moving this discussion forward with this group. Thanks a lot to everyone.
Thank you, everyone.
Thank you.
Thank you.
Bye. Thank you.